On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Fire Company training space. My name's Sean Barinholtz. I'm anesthesia and adult critical care physician at Hopkins. I'm an active member here at Pikesville, and I have the honor of serving in the medical director's office as CAR 609. On behalf of Dr. Pollack in the medical director office, Dr. Sagel, who's here with us as well, CAR 606. On behalf of the EMS office, Director Shenning, Captain Willits, and Captain Stewart, undoubtedly who's online, and Captain Nats, who are very supportive. Thanks for being here. Thanks for what you do. Thanks for your dedication to lifelong learning. Thanks to the young people in the back, Ashley and Hunter, for making our live stream possible and making that work to allow us to broadcast this throughout the state. Tonight we have two speakers. I'm going to introduce, but I just want to add, so for the COVID update by Director Shenning, we're going to take a quick break, and then the online community, don't forget you're going to need to sign in again, and this is just for the MIM CEUs. Ashley, anything else to add for that? Anything else to add for the logistics of that? Okay, great. So our first speaker tonight is Dr. Charles Cummings. Dr. Cummings currently serves as director of the Cardiac Cath Lab at Sinai Hospital. He completed his residency in internal medicine at GBMC, followed by his fellowship in cardiology and fellowship in cardiac catheterization and angioplasty at Philadelphia Heart Institute Penn Presbyterian Medical Center. Dr. Cummings, thanks so much for your generosity and being with us.
Hey, thanks so much for inviting me. And really, I can't say enough about you guys, and some of these slides will show some of that. So one of the things I was saying, Dr. Barinholtz, is if this was a week from now, I'm not sure we'd be having it. The world's going to change real fast, huh? So I'm the director of the cath lab at Sinai, and one of the things that we started is door-to-balloon times, and the world has changed so dramatically. I've been an interventional cardiologist for 29 years, and when I first came out of fellowship, we were giving thrombolytic therapy. And it wasn't so terrible. Someone's had a heart attack. Sometimes it would work, sometimes it wouldn't. But there was a 2.2% risk of intracranial bleed, and we'd always have to weigh, what's the chance of this person dying from the heart attack? Do we want to give them a stroke, et cetera? So then came angioplasty rescue. Then there were a lot of trials. And then with the advent of stenting and rapid intervention, we've really changed things a lot. We have some other technology like intra-aortic balloon pump, external heart pump. And I'll show you, it's a little bit of a show and tell today too. So I'll go with some of that stuff on these slides as well. But I really have to say some of the biggest congratulations actually goes to this team right here, because the sooner we get these patients to the hospital, the sooner we can open up the artery. And you'll see by this data, it's unbelievable how fast we're getting these patients in. You guys, this team, first responders, getting them to the hospital so quickly. So this was, these are EMS STEMIs at LifeBridge for the last calendar year. And I didn't do too many, I didn't want to go crazy. But it was also sort of a show and tell. I think that was sort of the goal for tonight. So very frequently we get EKGs now from the field. That's probably cut our mean door-to-balloon time. And we now say FMC, first medical contact to balloon time. So when I was first a fellow, there was a trial, well actually I was first attending, there was a trial called DYNAMI, and it said if you can open up an artery within 3 hours, patients do better than if you don't open their artery up. So it was really felt that, well, okay, 3 hours. So initially when someone would come in with a heart attack, let's say 15 years ago, someone would have a heart attack in the field, they'd do an EKG, we never transmitted it, you'd call and say, look, we think we got a heart attack here, bring them in. Okay, so then they'd call the cardiologist on call. He would take 20, 30 minutes, finish his shower, pick up the phone. You called? Yeah. He'll come in, see the patient. Yeah, this is a heart attack. We better call the heart team. Another 45 minutes, an hour goes by, the heart team comes in. The technology wasn't as good. We'd open up the artery. Sometimes it would work, sometimes it wouldn't. Then they came up with the idea of rapid revascularization, door-to-balloon times. Let's try to get an artery open within 90 minutes. Well, for the first 5 years that we did that, we didn't do so well. Nationally, it was only about 30 to 40% within 90 minutes. So we kept pushing it and pushing it and pushing it, and we kept getting better and better and better. Now, I can't be more than 30 minutes from the hospital when I'm on call. No one in the team can be more than 30 minutes away. And we get graded on every one of these things. So it's really worked. So I'm going to go through a little bit of show and tell, and actually some of the show and tell is FMC to balloon time, 83 minutes. So once we started tracking this number, 83 minutes from the time the first person opens the door to see this patient to the time their heart is open, to the time that artery is open, 83 minutes. So this person comes in. This EKG is a little tricky because there's some arrhythmia, right? There's some PVCs here. But as we remember, these bottom leads, 2, 3, and F, that represents the bottom of the heart. These are the anterior leads, V1, 2, 3, and V4, 5, 6 lateral. So leads 1 and 2 are lateral. These are lateral. These are anterior, and these are inferior. So in this case, we have ST elevation, 2, 3, and F. So this is probably a right coronary artery occlusion. And I think by anyone's standard, we would consider this an acute MI. This is such cool technology, right? So here's the angiogram. So this is a 6 French catheter, 2.0 millimeters. This is also half the size of the ones we used to use, 2 millimeters. And through this 2 millimeter catheter, we do an angiogram. We can see this clot here. That's my finger when I made these pictures last week. And here's the occlusion. There's a thrombus right here in the middle of this vessel. And so we opened that up. And I'm not gonna go through too much of bragging about the job we do. See if I can get back to the slides. Oh, here, X out. There we go. So that person did very well. And it's really rewarding. And I know you guys sometimes, bring someone in, we'll go right up to the cath lab, and sometimes you'll sit in the control room behind the lead as we do this stuff. And it makes us feel good, and it makes you guys feel good to see another life that you saved. Now here's another EKG. This is another one. This is very early last year. This is really early into us looking at this first medical contact. In fact, I think, was that when we first started looking at it? Was January 1st last year? Was that when they started to get graded on that? Anyway, so this EKG is ST elevation inferiorly also, leads 2, 3, and F, also laterally. So sometimes this could be a circumflex artery around the back of the heart, dominant circumflex, or the right coronary artery again. As remember, there's 3 arteries in the heart, LAD up front, right coronary around the right side, and the circumflex around the back. So this is another case of a very large right coronary artery, and it's really tortuous. And this was not my case, but it's a very large right coronary artery. And the physician who did this case really did a wonderful job getting this artery open quickly. You can see it's almost a dissection, a spontaneous dissection. Okay, now this EKG, any good EKG, you're not allowed to look at this, or Jeff. So here's another one. So there's some ST elevation here, again, 2, 3, and F on the EKG, so maybe the right coronary artery. But here, we also see ST elevation here with QA. So this could be anterior or could be inferior. We're really not sure. This is another case. Door to balloon, 40 minutes, and first medical contact. And these are not filtered. I didn't just bring all the good ones. I just went through all the ones early in the year last year. Oh, this was my case, actually. So here is a very interesting lesion. So this is the left anterior descending artery. And it comes down, which looks perfectly normal. Here's a branch of the LAD, and right here it's completely occluded. It's just cut off with thrombus. There's very interesting anatomy. So this is the artery down the front of the heart, halfway down, completely cut off. And this person was having a pretty big heart attack. So in this case, I don't know if you can see this from the back, but we have a wire across the blockage. I think I'll have to freeze this. So we put a wire, here's this tiny little wire, if you can see this. 14 thousandths of an inch. So if you think of a guitar string, it's the smallest string on a guitar. That's about the size of this, maybe even a little smaller than that. So we get a wire across it, and frequently just getting the wire across starts to reestablish flow. And then here it is. So this artery is now nicely open. So here's where it was completely cut off. And there's a stent from here to here. And it's just beautiful. So this 2/3 of the heart now, supplied by this big anterior descending artery, is widely open now. You hear that's someone in the back of the background bragging about our result, Cath lab number 2. This is an interesting EKG. So this is the EKG from the field, and this is one upon arrival to the hospital. So in the field is very dramatic, really impressive ST segment depressions in the anterior leads. So the front of the chest is leads V1, 2, 3, 4, 5, 6. So the ST changes in the front of the heart are massive and down going. So that can be two things. It can be anterior ischemia or posterior infarction. So this patient was so dramatically sick with big ST segment depressions inferiorly and anteriorly. We thought, well, maybe this is a circumflex because this patient was having so much pain. It was hard to imagine this was just ischemia. We really thought this was a heart attack. And that was actually, I don't think I burned a film on this one, but this was a circumflex. The artery that goes around the back was completely occluded. And again, door to balloon, 72 minutes. We didn't call it a STEMI from this EKG in the field because it was ST depression, not elevation, so we wanted to see the patient. Here's another, this is another interesting case. It's hard to, I apologize. So this is, sometimes we photocopy these EKGs from the field. There was just some subtle changes in the field, maybe some ST elevation. It was questionable. And here, you see it's sort of a questionable takeoff, up sloping. So we called it a STEMI anyway, and in fact it was. And I think I might have I don't have a film on that. So it was subtle findings. Troponin was elevated. We brought the patient to the cath lab, and indeed there was an occluded artery. This one, this is another one where the STs go up anteriorly. This is in the field. Not so bad. This could be left ventricular hypertrophy, or it could be a heart attack. But then when they got to the hospital, it looks a lot more worrisome. STs, the J point, which is that segment right after the EKG, is up. And this one looks really worrisome. We sometimes call these Tombstone EKG. Did I burn a film on this one? This one was, the initial EKG was completely normal, and then the patient came in with these EKG changes, inferior leads. This is one from the field also. So this one it wasn't able to be transmitted, so we couldn't determine what to do based on the transmitted EKG, but clearly there appears to be a big inferior infarct. When they got to our hospital, it confirmed, and it indeed was the same thing, a right coronary occlusion. This one, again, I apologize, these are the ones from the field that we photocopy. But this one, oh yeah, clearly some very concerning EKGs from the anterior wall, very concerning. On arrival to the hospital, very dramatic ST elevation. And I think I did show you the film on this one. Or not. Another big anterior, this is more like what we call Tombstone ST segment elevation. And we sometimes see this on arrival, or sometimes if someone has an occluded anterior descending artery, it starts to collateralize. You know, they've had it maybe 2 or 3 hours before they call 911. And then they come in, we open the artery, and it looks like this. So this is Tombstone ST segment elevation, anterior infarction. These are the ones where you guys saved their lives by getting them in. Another massive anterior infarct. This is very, very dramatic. Massive anterior infarction. How about this one? Pretty dramatic EKG changes, right? Called in the field. Because we called this from the field, this guy, in fact, I know this guy, we got this from the first medical contact, 69 minutes, from the time open the door going into the house to the time this guy is saying, oh God, I feel so much better right now. 69 minutes, that's amazing. Door to balloon time, 30 minutes. So that when he arrives in Sinai Hospital, Ambo Bay, 39 minutes from that time we hit the button to the time the arteries open. And dramatic inferolateral infarction. I think this was circumflex. I have some cooler stuff towards the end, so I want to show you some technology. I just want to whip through these. Another incredible case where you guys called it from the field. We saw the EKG, agreed. This technology is incredible. One of the other things that really, really saves lives these days, this thing called a cell phone. I get a picture from the emergency room. I used to have to go downstairs to my fax machine, pull out the fax. Yeah, it's a heart attack, and then put the phone back on, call them up. So now, of course, the ER sends me a copy of the EKG. You guys have phone numbers for the ER. Say, hey, this is what we're going to do. You have the box, of course. That's kind of cool technology. But anyway, so this really probably saves 30 minutes from heart attacks by getting them in so fast. And this isn't filtered. I mean, we've had amazing door to balloon times and first medical contact balloon times. This is another case of an inferior infarction. Another case of an inferior infarction. Sometimes when you have ST segment elevation inferiorly and big ST elevation depression anteriorly, it's because there's a right ventricular infarction. So the right coronary artery wraps around and it really knocks out part of the right ventricle as well. Big inferior infarction. And this was a very difficult access, but it was still 111 minutes from door to balloon time. And here's some ST depression. This is a very technically challenging case. This is really not as obvious on this EKG. Just some subtle, just a little bit up, some ST depression. So the initial EKG was negative, and even this is very borderline, but we decided to bring the team in on this, and it was an inferior infarction. This was the transmitted EKG, so the quality of this isn't so good. But when we got to the hospital, we were very impressed with this ST segment elevation here laterally. Again, first medical contact 106 minutes, and door to balloon time 75 minutes. Again, these just incredible times. How about this one? So this is anterior lateral infarction, big STs up. So this one has some arrhythmia. Sometimes it makes it a little more difficult, some baseline wandering. Maybe the patient's moving, they're very uncomfortable, but clearly there's a big infarction. Inferolateral infarction. 44 minutes, first medical contact, 79 minutes. Incredible. This is really a disturbing EKG. Profound bradycardia, massive ST segment depression. This is very, very concerning EKG. 1.5 hours of CPR. This patient actually did survive. Here's a case, big inferolateral infarction. I'm going to talk to you in a second about some cool devices that we have that we can, this one, big ST elevation anteriorly. You know, sometimes these patients sit for 2 days, 3 days before they call 911. Sometimes they start to heal before we get to them. So sometimes a wire doesn't go past the occlusion. We have some neat devices for that. We don't usually use anything too crazy during a heart attack. We just want to get the artery open. This is a case, a massive ST segment elevation inferolaterally. This is a very, very disturbing EKG. This is a BLS unit with no EKG, but it was still 86 minutes door to balloon time. So I'm not sure exactly why we're not allowed to send it in by phone if it's a BLS unit. I don't know if there's rules about that with HIPAA and all that. My understanding about HIPAA is if it's saving someone's life, you're allowed to do it. You know, you can't say, hey, is my ex-girlfriend pregnant? You can't do that, but I think you can if it's to save a life. Tell me the answer to that.
I think the limitation is the BLS providers being able to conduct the 12 lead.
Got it.
I think that they easily can transmit it, but it's the placement. So
Got it.
Program that the BLS providers can do or practice placing the 12 lead, and then we encourage that if that's true, and they know how to place the 12 lead, yeah, they should
Send
be
it.
doing that.
Good.
Send it.
Another one, big anterior infarction. And so we look at these times, we're graded on these times, but if someone is getting CPR or extended CPR that delays us, it's something beyond our control, so we don't get dinged for that. Or for example, someone's having a stroke and a heart attack, they have to get a CT of the head first, we sort of don't get dinged for that time. But these times are still incredible to me. I mean, this is just, especially an old timer like me who's been around when it was, 2-3 hours before we opened up an artery. So this is a quiz EKG. So this person was found down in December. Alcoholic found down in a house in December. That's a clue. Does anybody know what this is? So these are called Osborne waves, and this is found in profound hypothermia. And we had a case not too long ago. So you get these people that are still confused, and we see this, it's called J waves. So, you talk about J point elevation, so that the PQRST, that J point is right after the QRS, the big complex. So right after this complex, this point right here is called the J point. And there's a J wave. So this is a J wave. This is a J wave. You might say, well, this is like a right bundle branch block, but it's going the wrong way. But it's actually a J wave. And these are called Osborne waves. And these are seen with profound hypothermia. I thought this would be kind of interesting because you guys might see something like this occasionally. And even the ER doesn't necessarily recognize this. This is sort of a cardiologist esoterica. And this was, we found J waves on a patient not too long ago. And he actually wasn't, the one that we had most recently wasn't an alcoholic, but I think it was on psychotropic medications and somehow was, he wasn't in a freezing cold house or anything, but I think that his brain, he didn't cover himself up and it was a cooler night, et cetera. So, this is chest pain in a 27-year-old 1 week after upper respiratory infection. So what do we think about this EKG? Do we think this might be a heart attack? Maybe, right? Here's the J point, but it's not like, so when it's upsloping like this, we don't usually think it's a heart attack. So this could just be someone's normal EKG, but actually if you look more closely, the PR segment between the P wave and the QRS complex is depressed. And there's sort of these subtle ST segment changes lots of places. They're up all over, and the PR segment is down a little bit here, and especially here, and especially AVR, it's elevated, the PR depression. So this is actually pericarditis. And we see this frequently, maybe once a week. if you're not sure this person's still having crushing chest pain, we sometimes bring them to the cath lab anyway. But this one we knew was pericarditis. We gave them some non-steroidals, and they got better. Sometimes you'll have troponin elevation because the myocardium gets inflamed. This is some really crazy technology. This is part of the show and tell part of the program. So this is a 67-year-old woman who has diabetes. Her son is a doctor. Her daughter-in-law is a doctor. The other daughter-in-law is an attorney. They're Baltimore people. So I did the cardiac cath for this woman who was having severe chest pain. I don't remember if this is a STEMI. But here's the catheter, and this is where the catheter ends. And this is the main artery into the heart, and it's down to probably 1/2 millimeter or 1/4 millimeter in diameter. And this is a large circumflex around the back of the heart, and this is the left anterior in front. So we said, you absolutely need to have bypass surgery. Absolutely, I'm not going to have bypass surgery. I'm 67 years old. I've had a good life. So she declined bypass surgery. So we said, well, we can try to put a stent in here, but that's kind of crazy. So what we did is put her on sort of a percutaneous heart pump, and that's what this is. This is the this is called the Impella Device. So this device, I actually have one in the car. I was going to bring it for show and tell, but I was running late. So this is basically a high-speed propeller, like on a jet ski, an Impella inside of a jet ski. So there's 2 propellers, one in the front and one in the back, and it basically sucks blood out of the heart and up into the aorta. And Jeff knows about these. We can have a heart completely stopped, and a person can be talking to you. There's no pulse at all. And the blood pressure, if we look on the arterial line, will be a solid 80 or a solid 90, no pulse, and they're talking to you. So we put this in first, and then I put a stent into this woman's left main artery. I don't have a picture of the final result, but I put a stent in the left main artery. Oh, here's the result, actually. Yep, she comes to see us in the office. This was a year ago. She's come in twice already, and she's doing well. Jeff is not going to want to do a gallbladder on this lady when we stop her aspirin and Plavix, that's for sure. So she's stuck with blood thinners for the rest of her life, but she's still doing great. This is a fellow I just saw in the office last week who, this is about 3 years ago. He's a physical therapist. He's got diabetes and chronic renal failure. This should be CRF. He had a cardiac arrest at work. You guys showed up. He was getting bystander CPR. You came by, shocked him, got some heart rhythm back, bagging him on the way into the hospital. And we brought him right up to the cardiac cath lab. And this is what we found. He has severe multivessel coronary disease. This is a big circumflex around the back, just critical disease, critical disease. These look okay, so when the surgeon bypasses, they can bypass here and here, and they can maybe get a bypass here or here, but it was something that absolutely could not undergo coronary angioplasty, so we put a balloon pump in, and he went on a cool device. The pun is fully intended. Oh no, tell me. Oh, here it is. This is called the Arctic Sun device. So what this does is cools down the body temp. So I believe he came in on a Friday. So we did the cardiac catheterization, but he is still unconscious from CPR, and he's not waking up yet. So we put this device on, and for the next 24 hours dropped his body temperature and slowly warmed him up over the following 24 hours. And Sunday morning he starts to wake up after getting prolonged CPR. He's got a balloon pump in to keep the heart working. The next day, he got coronary bypass surgery, and he's doing great. So it was bystander CPR, then you guys show up, they do a higher quality CPR, and bag him, get him into us. We put him on this really cool device, and he's doing well. It's been amazing. So we've had, for whatever reason, we've had about 4 physicians out of the last 8 patients that wound up having full cardiac arrest with great survival stories. There's a doctor at Sinai Hospital that had this who's still working. There is a physician from Mercy Hospital who had just retired, who's now down in Florida playing tennis after a full arrest and subsequent revascularization, who were completely unconscious. You know, most people back in the day would have said, that's it, get the family in, take them off the ventilator, and that's it. But we cool them down. And you know the story. You're not dead until you're warm and dead. So we keep them cold, warm them up, and then make a decision. This let me see why. This guy had chest pain. It eased up by leaning forward. I forget why I threw this trick in. Oh, there's ST flip T waves inferiorly. So this is clearly not a normal EKG. So this guy has chest pain. It eases up when he leans forward. That makes us think of pericarditis. But in this case, he was found to have this big thrombus. I didn't make a picture of this. It takes a long time for the computer to digest that, so I just made a still frame of this. But this is the circumflex artery around the back of the heart, and there's a big thrombus right here. This clear part is a clot. This was just 2 days ago. And we aspirated that.
It's kind of an underwhelming EKG, too.
Yep, it's right. In fact, they weren't that impressed by it, but the troponins were up, and they shipped them. So this is the artery, the circumflex artery, that can really sometimes underwhelm us on EKG. So the LAD, look at the ones we looked at in the beginning of this, right? LAD, right coronary, LAD, right coronary. Those EKGs are pretty obvious. Circumflex EKGs can be subtle, or barely change at all. The other thing is, an EKG is really important. An old EKG is really important. And we have CRISP now, where we can look at someone that had a procedure at Hopkins 2 weeks ago. I can sometimes pull up their EKG from there, et cetera. I can get any EKG done at any LifeBridge hospital, but we can sometimes now pull them up from other hospitals. Someday, hopefully, it's crazy because the government forces us to computerize, but it doesn't necessarily to make the computers talk to each other. This is a 54-year-old male with hypertension, hyperlipidemia, smoker, with a cough. He just flew in from Wuhan, China, changed planes in Italy. And then he comes to Baltimore, hit in the face by a squeegee kid, and he gets chest pain while trying to run the kid down. So what's this guy's EKG going to look like? So here's his EKG. So, oh man, this is a big anterior infarct. Actually, no, this is left ventricular hypertrophy. So this is just an LVH EKG. We frequently get called with these, like, wow, is this an infarct? But it's very, very high voltage. You have impressive ST segment depression opposite the QRS complex. So even though the STs are up anteriorly, there's a massive QRS complex with the STs in the opposite direction. So this is good old LVH. So this story is not true, of course, but it's just an example of how sometimes we get fooled by LVH. Now, if this person were having crushing chest pain, you sometimes still have to bring them to the cath lab because you never want to make a mistake the wrong direction. And frequently we get calls from the field with something like this, somebody with crushing chest pain. We'd rather have the phone call than not, right? It's better to err on the side of calling it than under-calling it. You never want to miss one. This is a terrible case. This is a 74-year-old guy with crushing chest pain. I mean, just writhing in chest pain. Oh, please tell me that I'll see if I can go back to that one. So I'll go back to the EKG again. So that was a 74-year-old guy with crushing chest pain. And the EKG was sort of a right bundle branch block, and really, again, not terribly impressive, but okay, here it is. 74-year-old guy with crushing chest pain. And some ST segment depressions inferiorly, a wide QRS complex. This is the actual tracing. So, and there's sort of a right bundle kind of pattern, but there's this ST up in lead V2, which you don't usually see with a right bundle branch block, and a wide complex. The crushing chest pain, you think, well, maybe this is an aortic dissection, because it's not really a classic STEMI EKG. And do we have a couple of minutes still? So, so the reason I wanted to show you this one, this is an unusual case where we actually had no choice but to bring him to the cath lab, which turned out to be a fortunate decision. So he actually had a completely occluded left main artery. So he was living on a right coronary artery, which happened to be a decent-sized vessel. So this is his main artery. So all those vessels that we're supposed to see, this is it, 100% occlusion. So this is a fatal angiogram. This is usually completely unsurvivable. But again, because he got to the hospital so quickly, he was able to survive at least this much of it. I think I can. So here it is after I got a wire across the occlusion. So here's the main artery. You can see a bit of the wire, but this is just one image. But I was able to wire both vessels and balloon them open, and I put an intra-aortic balloon pump in, and he survived, which is extremely rare. I mean, that was a very dramatic presentation. And the lesson there is the EKG wasn't that crazy. I mean, it wasn't like, oh, this is a massive infarct. And again, we get fooled a lot of times by chest pain like that. And sometimes when the EKG is not that impressive, we bring them to the CT scan first, look for aortic dissection. But you see it, and unfortunately you have to get back and stuff. But anytime anyone ever wants to come and stay in the cath lab after an event, you're always welcome to at Sinai Hospital for sure. I never ever discourage first responders from sticking out, watching the procedure done. It makes everybody's job a little more rewarding to see someone crushing chest pain, and then a half hour later they're saying, "Hey, thanks, doc. I feel great. You guys did a great job." So I had a little show and tell stuff, but I know I was running a little bit late. So I have an Impella device and a balloon. If you want, I'll bring it in. You guys can maybe get set up for the next presentation. Is that okay? Great. Why don't you guys get set up for the next presentation? In the meantime, I'll bring those devices in. Oh, does anybody have any questions about any of those cases? Thanks so much. Yes. So the question is, why do we cool someone down and why do we slowly warm them up? So when someone gets extended CPR and they're not awakening, especially someone's found down, like that fellow was found down, they get bystander CPR, maybe not such high quality CPR. There's decreased brain perfusion and tissue perfusion. So we cool them down, just like if you get a steak, you want to keep it cool in the car on the way home on a hot summer day so it doesn't go bad. So we want to keep the brain from spoiling and the heart from spoiling and the other organs from spoiling. So we cool the body down, and then as the heart starts to reperfuse, we slowly warm up the body and then see what's working. So we cool them down, give them sedation, and then slowly wake them up. And the results have been phenomenal. It's hard to do a randomized trial because you don't ever want to not give it to someone. The reason we do that is because, as you know, drownings, someone drowns in cold water, sometimes they can be down underwater for 30, 40 minutes, and you resuscitate them, and you say, well, they're gone, but they're not gone until they're warm and gone. So a lot of times these drowning victims can be under 30, 40 minutes in cold water, near freezing water, and wake up and be completely brain is working. So how can that happen? We know if you don't have blood to the brain in 5 minutes, you're cooked, not if you're in cold water. So because of that, we cool down bodies and slowly bring them up and preserve the brain. It really does, it's incredible. When it works, it's unbelievable. A 100%. So for every STEMI, there's two so the question is, how about non-STEMI? So STEMI is ST segment elevation MI. They're even looking at class 1, class 2, class 3 MI, but still STEMIs and non-STEMIs. So STEMI is ST segment elevation MI, so that there's no question from the EKGs it's a heart attack. So that's easy, right? How about non-STEMIs? Someone has crushing chest pain. We check their blood enzymes abnormal. So what about those? So that's why we still, even if EKG is normal, we still get called in. The troponins are up. They're still having chest pain. It concerns us when someone's having a lot of chest pain and the EKG is normal. We have to say, is this a aortic dissection, pulmonary embolism? So we have to rule out other things. And usually it's not as disastrous. If someone's having a non-STEMI, usually have a little more time to think. Once there's no dissection, we can put them on blood thinners and we say, what else is going on? But you're right, non-STEMIs are very, very important. And it's very important to revascularize those because those are the ones that can, if you miss it, someone has a non-STEMI, you send them home, they're very high risk for another heart attack in the next few weeks. Those are patients who don't have a completely blocked artery. They have a 90% blocked artery or 95%. So that's a very important point. Yeah, we do tons of those. We wouldn't have enough time to look at all the non-STEMIs in last year. Well, thanks. I'm going to run out and just get an intra-aortic balloon pump just to show everyone in that Impella device. They're really, really neat stuff we can put in. Thanks so much.